Kind of in half years.
Good morning, everyone.
A dialogue.
I think it's 10:30 by that clock there. It's our third meeting of 2015, and I think we've picked a good day for it. So, if you're wanting out to top up your tans, I would suggest brief questions, brief answers, and we'll keep going. I'd like to take this opportunity to remind members that this meeting is being recorded and will subsequently be available for public listening. On the subjects of recording, I would ask that you ensure that you use the microphones at all times when speaking, or I think these are quite good at picking up the sound, and that you speak clearly, and hopefully we'll get a good recording of this one. Item 1, Sederunt apologies. Lucy?
Good morning, everyone. We have 6 members present today. We are quorate, and I have apologies from Councillor Brodie, Councillor Karen Crothers, Councillor Dykes, Councillor Weichert and Councillor Prentice are not present, but may be along later.
Item 2, declarations of interest. Do any members have any declarable interest today? No hands going up. Item 3, minute of meeting of 16th of April for approval. Take that as a correct record, those that were here.
Yep.
Right. Thank you for that. Move on to item 4, scrutiny review, phase 2 commissioning, presentation and evidence session with the Scottish Government and Joint Improvement Team. At our last meeting, we agreed to take evidence from witnesses as part of the next stage of our scrutiny of commissioning. We are therefore lucky to have with us today Brian Slater from the Scottish Government and Katie McWilliams from the Joint Improvement Team, who is here to replace Christina, who was meant to be down but otherwise engaged. Brian is going to cover general national issues around commissioning, and then Katie McWilliams will talk about the capacity building and capability work that the JIT is supporting. I take it you'll know that it's a reasonably informal sort of situation we have here. People ask questions, etc. I believe you've been sort of briefed to give us a couple of introductory remarks, small presentation, and then at the end of that we'll open it up for a sort of discussion session. Members might want to ask questions. So I'll hand it over to yourself.
Okay, thank you very much for the invitation. I'm afraid I don't have a presentation because I was told if I had a presentation we'd need to move to a bigger room. So I don't have a presentation, but I can give you a quick overview. My particular interest is around health and social care integration. I work in the Integration and Reshaping Care Directorate within health in the Scottish Government, and I lead on strategic commissioning. Now, commissioning in some quarters has been seen as a bit of a dirty word, those quarters mainly being NHS quarters, where there's a worry that it's confused with commissioning as is seen in the English context down south. The NHS will tell you they have always done strategic planning, and they have, but they do strategic planning almost in isolation, and they do that without any budgets particularly being linked to the way they do their planning. Commissioning has been done in local authorities for a number of years, but the Audit Scotland report of 2012 was somewhat damning in their judgment that commissioning wasn't done particularly well anywhere. Now, joint strategic commissioning between health and social care, we'd always thought we were playing catch-up with England until we were invited down to a meeting in London by the King's Fund, who we presented where we were in Scotland, a very sort of honest appraisal of where we thought we were in Scotland, and the King's Fund came to us at the end and said, we need to come up to Scotland and learn from you because you're so far ahead of what we're doing in England, which was quite pleasing but also quite worrying because we think we've got a lot to learn, and I think we do. So what is strategic commissioning? I'll just quickly read the definition. And I'll read it because we have a national steering group on commissioning for which it contains the great and the good from a range of agencies, and they spent almost the first 2 meetings agreeing this definition. And in the end, it's more or less word for word the old SWIA definition from several years ago. And it is that strategic commissioning is the term used for all the activities involved in assessing and forecasting needs, linking investment to agreed desired outcomes, considers options, planning the nature, range and quality of future services, and working in partnership to put these in place. And it all sounds very sensible. It is planning, and planning with money alongside it, and planning based on a full assessment of local circumstances and local needs. And we're not just looking to develop existing planning that might have gone on in health and in social care and in some good areas where that will have been done jointly. We are looking for strategic commissioning as we now mean it and understand it to be a real game changer, to be something different in terms of integration. When we have our new integration joint boards, we're looking for these boards to really do something different, not just have more of the same. The legal requirements, the Integration Joint Board has to set up a strategic planning group, and this planning group needs to contain providers, independent sector and the voluntary sector. It needs to involve representation of carers and service users. And this is not just some sort of tick box exercise to say, well, we're going to involve the people that everybody says we should involve. They really have to be there from the start and right through the whole process. And it's a cyclical process that involves planning, analysis, planning, the delivery, and then reviewing and carrying on like that. So there is the plan that needs to be developed needs to be developed by April 2016. The integration joint boards cannot go live, cannot be fully functional until the strategic plan has been developed and published. And it needs to be a 3-year plan, and it needs to be reviewed at least every 3 years. Now that plan can in fact be longer. You can have a 5-year plan, you can have a 7-year plan, but it needs to be reviewed every 3 years. And it can be reviewed more often than that. If it's not working, we would expect it to be to say, right, it's not working, we're going to develop a new one. Had I had a presentation, I think that's probably all I would have put on it. Katie is with the Joint Improvement Team. We work hand in hand with the Joint Improvement Team. Apart from commissioning, I lead on other aspects of policy such as delayed discharge and intermediate care. And again, in those subjects, I always look at the Joint Improvement Team as almost being our soldiers on the ground. We can sit in St Andrew's House saying this is what we want to do on delayed discharge and just expect partnerships to go away and have no delayed discharges, which I must admit in Dumfries and Galloway for many years you did. But where areas are struggling, and again in Dumfries and Galloway you are starting to do that on delayed discharges now, the Joint Improvement Team are our sort of agents on the ground that help out. And it's the same with our policy on commissioning. Lots of support needed. I think the Audit Scotland report was very clear on that. There is a lot of work needed, and we're almost learning from each other on this. There's no experts on commissioning really exist in Scotland. So we're learning from areas that have good practice, and we will share that good practice with other areas as we go along and develop our policy. So Katie, I'm not sure if there's anything you want to say about your role?
Certainly, as far as just reiterating what Brian was saying, Christina Naismith and myself were brought on to work with the Joint Improvement Team about 2.5, nearly 3 years ago now. And you're quite right, Councillor Hislop, it was about capacity and developing capability within and across the partnerships. And we did that originally with a 3-day learning and development programme, which took agencies in each of the partnerships. So we had the social care staff from the council, we had NHS staff, we had third and independent colleagues as well around the table. And at that time, the kind of joint planning processes were probably more established in the field of older people's services because of reshaping care for older people and the work that had been done there. But as we progressed those 3-day learning development programmes, we were finding that more senior staff were becoming interested because of the bill at the time, going through that process to becoming an act, and recognising that for all community adult services, some functions associated with acute hospitals, that there was people were having to raise their game. So we actually had one GP, which was fabulous, but we've also had some people come on the course who have now become chief officers. So that was the original kind of learning and development, building capacity and capability. And Brian's quite right, although the process of commissioning and planning isn't new to people, the process of doing it together is what's new to people. So it was quite important that those 4 agencies and the sectors actually got together to recognise and understand what that might mean for how they work together, and ultimately how they develop their strategic commissioning plan. What the Joint Improvement Team through Christina and I then offered, we offered each of the partnerships at least one follow-up visit, because at the end of the 3 days, each of the partnerships came up with an action plan about what they required to do back in their own area to start developing their strategic plan. And the majority of that work was based around strategic needs assessment, as Brian has mentioned, as the first part of that, to identify what your population needs are, what's happening now, what kind of resources are being spent on those activities, and what kind of shape your workforce is in as well. What is being delivered from a statutory and non-statutory perspective, and how might that actually develop as things move on. So the Fries and Galloway, like all the other partnerships across Scotland, have had that follow-up visit, and indeed they've had a number of workshops. I think the last one was perhaps February this year, where again Christina Naismith attended that and helped facilitate, along with John Patterson, who's your designated partnership lead from the Joint Improvement Team. So he's the kind of week-to-week, month-to-month support, whereas Christina and I have the kind of specialist knowledge, or we're taking forward the kind of subject matter of strategic commissioning because of the experience we have. So that's the kind of building capacity and capability. What Joint Improvement Team have also done on a regional and national basis is engage folk across the sectors as well on living well in localities, because that's the other key important part about the strategic planning process. There may be an overall vision about what Dumfries and Galloway the partnership want to achieve for the population from a health and social care perspective, but one of the requirements within the Act is also that each of the partnerships must have locality arrangements in place, and they must have at least 2 localities. And understand Dumfries and Galloway are quite advanced in their discussions about how those localities are going to move forward. So again, that gave quite a wide-ranging number of people from the partnerships, from each of the sectors, to come along and learn a little bit more about that, contribute what their own journey had been towards their locality arrangements thus far. And some, again, as we move across the country, some are quite well established. They're maintaining, the old kind of electoral ward neighbourhood areas. For instance, some are taking a slightly different approach. So we're in the process of continuing to support partnerships to build their own capacity and capability, because it's about probably new relationships, new ways of working, and as Brian's quite rightly said, that because of the drivers for change, because of the growing number of older people that may require help, the growing number of even younger people, the 50-pluses, with multiple conditions that are going to require supports and services, a new way of working and a different way of delivering care, which is affordable, is going to have to be devised through the strategic commissioning plan. Within that, there's a relationship with procurement and purchasing, and procurement and purchasing, as we know, for support and care, can probably really only occur once there has been a good foundation of commissioning, planning and identifying what is going to be required as we move forward. So that's the kind of relationship between the commissioning planning part and the actual procurement and securing services to deliver against the plan as well. So that kind of makes that connection between commissioning and procurement. Happy to take questions. I don't know if there's anything else you want to add from what I've said.
No, I mean, I think the only people that might be missing if we had a sort of triumvirate of all the people involved in
Yeah.
commissioning, would be our analysts, Information Services
Yeah.
Division of the NHS, who since the Act, the Public Bodies Act, now have a wider remit across public services. They've been doing a lot of work to improve the quality of the data that's going to be available locally. What they're doing is linking health and social care records so that they can plot the whole pathway of people, so older people or younger physically disabled adults. In the past, we might have had reasonably good social care data up until they go into hospital, and then we get the hospital data, which can be quite good in sort of plotting where they are within the NHS system, and then they come out and they go back into social care data, and again we have a reasonable plot from there on in. It's never really been joined up. ISD are linking all those records now so that we get a complete pathway of people, and we can start to get really good local data that can be broken down and from a national level to a local level to Dumfries and Galloway. It can then be broken down to your localities. It can be broken down to GP practices. Because we have it at this individual record now, we can start to understand where the spend is occurring. And from that, we can start looking at the variation between GP practices, between different localities. And since we're, for GP practice, one GP practice is actually spending far more on hospital admissions than the GP practice next door, we can start to look at why that is. And there might be justifiable reasons. But the information is weighted. So, again, we can start to look at this and wonder why if one is spending sort of 3 times as much as the GP practice in the next locality. What are the reasons behind that? So the data is going to be very important in the analysis stage of drawing up the first strategic commissioning plans.
I suppose the only other thing I would add is that one of the other reasons that information is really important to have is so that we can move from dealing with people who are in crisis and who need help at a moment of crisis to try and prevent that crisis from occurring. So the other key element of the plan is about what resources and what attention will the partnerships give to prevention, inequalities, and trying to prevent some of the crises occurring in the first place. That there aren't a lot of people who use our services across the country, but those who do can often be quite high level users of services. And if that's what's required, that's fair enough. But there are also those where quite a bit of time, money and effort should be spent on trying to prevent illness and crisis occurring and promoting health and well-being, as we are all living longer as well. And quite a lot of the capacity within the community is really, really crucial for that to occur, that kind of asset-based approach associated with, things like walking groups, how you get the leisure facilities involved, etc., and keeping people fitter and healthier for longer.
I asked our analysts yesterday afternoon just to give me some headline figures. I said, so I'm going down to Dumfries tomorrow. Can you give me something that's really going to wow them? Now, I think this, I've only got about half a dozen stats here, but I think they're real eye-openers. Dumfries and Galloway residents use up 172,000 hospital bed days in a year, and 86% of those are unplanned. So 86% of those hospital bed days have not been planned, not been scheduled, and 50% of them are used by the over 75s. 21% are used by people in the last 6 months of life, and it's our policy that people spend the end of their lives in their own homes if they can. That's what people want to do, or in a homely setting, not in a hospital. But 21% of those bed days used by people in the last 6 months of life. We break it down by what ISD referred to as high resource individuals. And from those statistics, 2% of the over 75 population use 50% of all the hospital and prescribing costs. So 50% of the hospital and prescribing budget is accounted for by just 2% of your population. And 75% of that spend is on unplanned admission. Now, just to break that down into some numbers, we're talking about 3,128 people across Dumfries and Galloway, and they use £77.2 million of hospital and prescribing money. And those 3,128% account for 86% of all those hospital bed days. So some quite staggering statistics within that the the planners really need to get into and dive deeper into, because if you could, I went to the Western Isles about a month ago, and I asked them for the same data. And in the Western Isles, statistics are the same all over the country. 2% of the population use 50% of the spend. In Western Isles, that was about 350 people used, I think it was 19 million pounds of resources. Now, my question to them was, surely you can know these 350 people, and you can get in about these 350 people and really start talking about a preventative agenda that can keep these people in their own homes and stop them going into a hospital system in the first place. And from that moment on, they cost more and more money as they come out of hospital into residential care, into huge complex packages of care. The argument about preventative care years ago that I remember having with COSLA when we introduced the Change Fund was, I was saying, we know the people that are spending tens of thousands of pounds, yet we won't put in £500 or £1,000 worth of care right at the early stage to stop them getting into this pathway where they spend all that money. And their response was, well, you tell me a social work director that's going to just almost take that bet of £500 or £1,000 in the hope that they don't go on to spend that money. They're not going to do that. This data starts to give them that evidence and tell them the people that they actually need to be looking at, and predicts the people that they need to be looking at. And the numbers aren't huge in terms of the number of people, but the numbers in terms of the budget, £77.2 million, are really quite enormous.
I just wonder what evidence you've got that the £500 or so care package would actually prevent it going further and then them ending up in hospital anyway, and
absolutely.
Maybe you've wasted another £500. I mean, I have no idea, but what evidence do you have to
There are
suggest
sort of
the
predictive tools that can predict who these people are going to be. And it is based on lifestyle, it's based on background, it's based on how many times you are turning up to the GP, how many hospital admissions you are taking. But there are tools that can sort of predict the people that we're talking about. So we can start to lower the odds, if you like, on taking that punt. It might be, well, it's a 10 to 1 chance if I invest that £500. Well, actually, if you use the predictive tools, you're narrowing the odds down to 2 to 1 or 3 to 1. And that's a better bet, if you like, that money is going to be saved in the long term. But, money is tight. There is absolutely no doubt about that. The preventative agenda is one that would suggest could make a difference. I think it's 40% of the total health and social care spend is spent on unscheduled admissions. So these are unplanned admissions to hospital, account for 40% of the budget. Somewhere across Scotland, I think it's £4.3 billion. Now, to me, that's the prize in integration. That's the pot of money we need to be looking at and say, we could save a huge whack of that, £4.3 billion, if we can put something in the community that stops all these people going into hospital. Now, we're not saying we want to just have nobody going into our hospitals. Our hospitals are there for a reason. They're there to treat people. But surely it should be planned. It should be planned between our social work staff, our nursing staff, our GPs in the community, knowing when somebody is going to need to go into hospital and planning that visit in the hospital. Because this 4.3 billion is totally unplanned, unexpected, unplanned, unscheduled. We must be able to do something about that by investing earlier on.
Is that like elderly people who are just taken ill, or is it accident and emergencies, or is it?
That would be both. That would be both. So I mean, we're not going. If a bus was to crash in Dumfries today, we're going to have a lot of people rocking up at our hospital front door to A&E. We can't predict that. We can't prevent that, really.
But what percentage of your total of unplanned is actually unpreventable accidents, and what percentage?
The vast majority is older people.
Yeah.
And like I said, 21% of the bed days in Dumfries and Galloway is people towards the end of their lives. Now, again, I don't know the reasons for that. Locally, your people here should be able to dig into the reasons for that. But people want to stay in their own homes or in a homely setting towards the end of their lives. We know that. That's all the evidence and the research tells us that. Yet we have a vast amount of bed days occupied by people towards the end of their lives. Now, I think all of your care home capacity in Dumfries and Galloway is with the private sector, I understand. I don't know the extent the Health Board is working with those care homes. They should be. These care homes are providing nursing care. It's got to be a responsibility of the nursing directorate within the Health Board to actually work with these care homes and say, well, if somebody you're looking after people increasingly at the end of their lives. There is absolutely no reason nowadays, with the care that can be provided in care homes, that these people should be going in and out of hospital to get care that could continue to be provided in the care home. Because when we talk about people's homes, these people's homes. They've moved into a care home, it's their home. Why do we keep on, if their needs start to sort of escalate, we call the ambulance, we blue light them into the hospital, we put them back to the care home where they stay another few weeks, and then we shoot them into the hospital again. Why can we not care for these people in the care home that provides nursing care?
And that is the key kind of quality element, I suppose, associated with what is hoped to be achieved with integration of health and social care. When I was speaking to a GP just last week, she was quite upset that one of the care home residents that she looks after out of hours was blue lighted into a hospital situation and was assessed, didn't require hospital care, and was transported back to the care home only to die 3 hours later. That must have been quite distressing for the lady herself, but it was also distressing for the staff. So it is about getting into a position where the staff within that care home feel supported enough, they feel capable and confident in the care plan for that individual, so that they are kind of taking the appropriate steps and the right actions, and also seeing to people's wishes as they are kind of closer to death, and people have the right experience, whether it's within a care home environment or indeed their own home, for instance.
Surely the care homes, it must be to do with the quality of the people who are working there. I mean, if they were fully qualified nurses and whatever else, they would have no reason to blue light anybody, but they're not. They're care home assistants, if you like, and they have limitations, and that's quite right. And you can't expect them to step up to the mark.
Well, care homes without nursing, I would take your point. I mean, the old, we only have care homes there, we don't differentiate. But the old style residential homes, yes, I would take your point.
Well, that's what we have quite a lot of in Dumfries and Galloway.
But I mean, their nursing input can be put into care homes. If they are residential.
Who pays for that, though?
Sorry?
Who pays for that?
Well, the NHS would pay for that.
Well, but would they if it was a private home?
Well, there's absolutely no reason why they can't. Nursing provision is in the main an NHS provision. Where nursing care is, local authorities can provide it, or can pay for it rather, where it's in care homes. That's from, I forget which act that's from, that allows it to do that. But there's absolutely nothing to stop nursing provision being put in to help care homes where people have nursing needs. Nursing care is free of charge. Whether that's paid for through the local authority or whether it's paid by the NHS, people don't pay for their nursing care. If nursing care is needed from people in residential settings where that nursing care is not being provided, there is absolutely nothing to stop the health board putting nursing staff into that care home to care for people. And it will be cheaper than hospitalising.
There are examples across the country whereby community nurses in the community, in the new integrated partnerships as they're developing, liaise with certain care homes to provide the advice, do some teaching, help people develop care plans, and again it's about building that capacity, capability and confidence. And in another couple of partnerships, for instance, they will be on call for pain management, that kind of thing. So there are examples across the country where the NHS has seen that investment worthwhile for the person's experience and from their outcomes perspective, but also for wider support of the staff that are working in that environment as well.
Right, we're sort of drifting off.
Absolutely.
This is specific to this issue rather than this sort of commissioning process that we were looking at to help us with that. And there's some.
I would counter that, convener, by saying that to me that it almost is a commissioning role, because the savings that could be made is in these unscheduled admissions. So anything that the commissioners can say, we need to build up the capacity in the community that will prevent these admissions. That to me is where the big saving and the big prize is to be made. So arguably it is linked to commissioning, but I take your point. We're drifted off slightly from.
Because I think what we were hoping to do was actually look at the whole process rather than specific to one, and how it's sort of working through Scotland itself. Andrew, did you want to lead on the first one, and then I'll bring
I was going to pick up just, is it okay if I do just in, the only reason I'm saying that is because I think it's relevant what Brian just said, because I was going to pick up the same point in regards to, we used to, Tree Estate in Annan, we used to have a like for like, what was being described there.
Yeah.
We had that lower level support, but the nurses were on hand, just in case. It was removed quite a while ago, maybe 8 or 10 years ago. But as far as from a commissioning point of view, everybody would like to see that coming back, and I think it's important, but we do consider that as we go forward in our commissioning. That style, but across the Fries and Galway, of course. Thanks.
Right, Andy.
Thank you. I was really to ask you, what is the current picture across Scotland? I know you've given us an overview, but I think we would all like to know exactly where we are at present. And I don't want just to restrict it to Scotland. Can you also give us examples of good practice internationally in other countries?
The nearest example would be to look at England. Now, we having been invited to speak with the King's Fund, we asked them for examples, good examples from England. We asked the Institute of Public Care, who helped devise the support programme that Katie mentioned earlier. They couldn't give us any. Or not that they couldn't, they weren't willing to highlight anybody in England as being particularly good that we should be learning from. What we want to do, there is the legal requirement, every partnership has to develop a strategic commissioning plan by April 2016. We have, your own older people's plan from a couple of years ago was developed, so we're not starting absolutely from scratch. Every partnership's done something on older people. What we want to do, I'm reluctant to sort of suggest that each partnership's plan is not going to be very good in the first year, but I think there is an expectation that this is an evolving process and they will get better. And they'll probably only get better once we see the initial plans that are coming in from partnerships. And there's only three local authority partnerships now that have gone live, are fully functional. And that's the three Ayrshires, North Ayrshire, South and East, are fully live as integrated joint boards. The expectation is that the majority of Scottish partnerships won't go live until April 16, which is the final end point. So we don't expect to see final commissioning plans really until April 16. I would like to think that most areas will review their plans and develop second plans almost within the first year of being live on integration. So we'll have a 3-year plan from April 16, and in April 17, or at least April 18, we'll have another 3-year plan because of the lessons that will have been learned from looking at all the other areas. Some of the drama, Katie obviously works with a number of partnerships, so I'll let her expand on this. A lot of the plans that we're seeing at the moment are very good on some elements. So they'll be very, very good on the presentation of data. Some will be very good at the analysis of that data. So we have a good understanding of where we are now, and we might have a good understanding of where it is we want to get to. Where the plans that I've seen at the moment in draft aren't very good at is the actual how we're going to get there, that leap that we're going to make. Because the commissioning part of it is almost the easy part. We can all look and say, well, all right, that's the pot of money we've got, and this is what we'd like to do with it in an ideal world. That's the easy bit. The difficult bit is saying, and to get the things we want, we're going to need to do less of these other things. And a lot of that will be unscheduled care. A lot of that will be things that we're doing inefficiently and ineffectively at the moment. But the decommissioning part is probably going to be the tricky part. I think that's where nobody, I would say, in Scotland has cracked it yet. And that's where a lot of the lessons that we need to learn will be learned, is the decommissioning. This is what we need to do less of to free up this money, to put it in here, to do what we want to do more of. But Katie, you work with half the partnerships in Scotland, so I'm sure you can elaborate on the good ones.
Well, I mean, I think your comments are reasonably, reflective of what is occurring across Scotland. I agree with Brian that I think a huge achievement for April 2016 will be to have all the information about your population needs and about the resources associated with that and about the workforce situation and about what your key ambition is for your population in Dumfries and Galloway. To have that all in the one place from a health and social care perspective for all the devolved functions will be a huge achievement. I think the the work about what we change, how we do things differently, how it looks and feels for people who are receiving care and support, will need to be worked over, and it will be an evolutionary process. The government have given the opportunity for people to test new things through the Integrated Care Fund, and that's a 3-year programme now, isn't it, Brian?
The money, I would argue the integrated care fund, the sort of change element of that is probably year one, but the budget has been extended, so the budget will be there in years 2 and 3. It will likely just sit within the baseline of the new IJBs.
Yeah. So the government have allocated that money to partnerships very specifically, to try things differently, with a key focus on prevention and with a key focus on that group of people that we mentioned earlier on that may have more than one condition and that may actually be in the system using care and support services at the moment. So that there is that opportunity to try things, because I think certainly my background is within health over the years. In fact, I did my nurse training here in Dumfries a few years ago now, and Christina's predominantly kind of social care background, so we have a good mix between us. But the opportunity to do things differently is there, and my experience is that we decide on a course of action, we move forward with that, and we try very hard to make that work. And I suppose what we've not often been terribly good at is reviewing where we are, identifying how it's impacting on people, thinking about whether it is working or not. Just heard the example was at Annandale about community nurses, and will that work for here? It might not work for there. And actually taking a deep breath and saying, actually, I'm not sure that the people who are receiving these care and support, they're feeding back, they're not getting quite as much out of it used to, as they should, and actually calling a halt to that in some way and trying something different, and having the ability and the confidence to do that as a partnership, but also giving things a chance to settle in and settle down, because change doesn't happen overnight, because we're talking about a huge workforce across both the statutory and non-statutory sector that have to think differently about how they support people and how they provide care as well. So one of the big things in thinking about the examples is that where I think partnerships will have a better chance of success is where they have made an absolute commitment to work with staff and do staff training, awareness, organisational development, to shift and change the culture within the staff group about them working differently as well. And certainly in my experience, I've found that quite a lot of staff on the ground working with people are the ones that come up with the best ideas about how to improve, about how to reduce waste, about how to not do things twice or forget to do something at all. So it's about using their expertise and indeed the expertise of the people who are receiving care and support, to improve things in the short, the medium and the longer term. So there are pockets of good examples. The Joint Improvement Team website has some of those examples available from the Reshaping Care for Older People days, and more recently as we're kind of getting into the wider adult care group and integration agenda. So there are some examples about specific care groups, for instance, if you want to kind of look up on that. And the King's Fund do have some information on their website as well. So the whole reason of the regional and national events that the Joint Improvement Team run about live well in localities is so that they're actually getting to know about what each other are doing and to take. I mean, we were saying at the last live well in localities event, steal with pride. At the end of the day, everybody's come with their information, they're willing to share that, and people take from that what they want in order that they can improve things back in their own partnerships.
Can I come back in on that? Do you find then that there's a more readily acceptance of the changes that are taking place when you look at the Highlands and Islands, in particular Shetland and Orkney, they have a very resilient mindset, that they tend to be quite independent, and therefore they have to ensure that they're working cohesively together. Do you find that this is quite a more positive, or is it quite negative because they like their independence?
Difficult, yeah. I think it's a bit of both. It's difficult to speak about particular areas without saying anything I possibly shouldn't say. there are absolutely huge pockets of really good joined up working in the islands because, like you say, that's what they have to do.
Yeah.
Are they at the forefront of integration? Probably not. So real areas of good working, but in terms of the legislative requirements, I wouldn't hold them up as being right up there. Highland obviously is a slightly different story because Highland integrated several years before we legislated for it to happen. So in Highland, they decided several years ago now that they needed to integrate their services, and they have what we call in the legislation a lead agency arrangement, whereby social work is delegated from the council to the NHS board to deliver, and children's community services has gone the other way. So it's been delegated from the board, and the council deliver children's community services. It's in its infancy. It's been going for about 3 years now. So they legislated 3 years ahead of everybody else, and I wouldn't say it's without teething problems, but they're the only area in Scotland that has so far, or at least before the 3 Ayrshires, had fully integrated. So Highland ahead of the game. Whether we would, I said there's lots of good practice in some of the Highlands and some of the other rural areas, the islands, but I'd have my reservations just particularly about highlighting them.
So, in your view, what do you see as the biggest difference between commissioning as we go forward and what we've always done in the past, which was, I need X amount of beds, I need X amount of this, that can be delivered that way, and actually just going out and saying, right, I've got 15 million to spend on that, you go and do it. What is the difference between that? And I would say that was normal procurement, where you list what you want, send it over to somebody, can you deliver that? What's the difference between that?
There's several things. That sounds, as you described it, incredibly top down, whereas we want strategic commissioning to be bottom up, based on localities and the needs of those localities, and that's how it should inform the overall strategic plan. That's why we want users and carers involved. That's why we want the providers themselves fully involved, and it's not just tokenism. We want the providers to be fully involved because they are the experts in what they can provide. I can come back to some examples from the Highland later if you want about how that can work in practice. In other ways, though, that it is changing. This is possibly not the case in Dumfries and Galloway, because I think you probably have done a lot of joined up planning in the past, but in other areas, yes, it's been planned like that. We need so many beds, but the we has been the health board or it's been the council. That's the we. So we decide how many care home beds we need for that council, or we decide how many hospital beds we need in our boards without any collaboration with each other. Now, I would argue, how on earth can you plan the hospital capacity that you need without knowing the availability of community care through the council? And how can the council plan their care home provision, their home care provisions, without knowing what the NHS can be providing as well? It has to be done in partnership, has to be done jointly. Originally, we always used to speak about joint strategic commissioning. We only started dropping the joint in the last few months because we've legislated now for it to be joined up. We've legislated for it to be done on a partnership basis. So there's several things there that needs to be bottom up and done through locality planning, needs to have the full involvement of wider than just statutory bodies, and it needs to be done in a truly joined up way is where I would say is the difference. And the strategic commissioning part and procurement, strategic commissioning should be, these are the outcomes we want to achieve, this is the money we've got, this is how we're going to achieve it. The procurement then is almost being told, that's what we want to deliver, you go and contract for it. It's actually it was summed up, and I'll probably get this story slightly wrong, it was summed up in a parliamentary committee by Annie Gunnar-Logan from Community Care Providers Scotland, umbrella third sector providers organisation, who described a council area or a partnership looking at how they delivered lunches, nutrition to older people. And they were looking at their frozen food deliveries that they provided to people that were then microwaved in their own homes. So they went to their people and said, we think we can get better value for our money. We want to have a tendering exercise to go out and find one company that can deliver throughout our area to deliver frozen meals for people to have for their lunch. And that's a procurement. That's procurement. A commissioner would say, we need to provide nutritional value to people, we need to feed them, and we want to do that in their own homes. How can we do that to meet those needs of people? That's a commissioning decision. That wouldn't necessarily be the frozen food delivery. It might be, but the outcome of that commissioning decision might be, actually we want to provide frozen meals, and to then pass that to procurement to contract and tender for it. But the overall commissioning decision is, what is it we're trying to do here? We're trying to feed our own older people to keep them in their own homes, and how are we going to do that? So that's how she described the difference, and I probably slightly misquoted her there.
Well, that's my question, really, which was, you know, the key aspects of good commissioning and how do we get away from procuring rather, you know, and commissioning. And I've just written down, you do it from the bottom up, locality planning, you decommission, which I think is quite an interesting thought. We only think we do that with nuclear power stations. I don't think we do it with anything else. But but what I really want, because your statistics were really interesting, and it's quite good when we get statistics absolutely pertinent to Dumfries and Galloway, and that's, I think, been quite an eye opener for us. Is that how you really do it, though? Do you use you go on statistics, really? Do you to commission? Is that the most effective way?
Not at all. You would go. I mean, we talk about commissioning for outcomes, and it's very difficult to get statistics about outcomes. So that really has to come from talking to individuals and finding out what it is that people themselves want. But statistics and the data that we have and the data that we are striving to improve is an absolutely vital, important part of it. Like I said, that was just. I gave them about 5 minutes to come up with this yesterday, saying, "Look, I'm leaving for Dumfries. Can you give me some figures that will wow them?" So we didn't spend. They didn't spend a huge amount of time on coming up with these headlines, and they gave me a few more than that, I must admit. And those were the ones that I sort of picked out and jotted down. But ISD are going to identify analysts that will work with each partnership. So that professional analytical support will be available from the centre to come out and help you. The data is becoming readily available. So what I would say to you at our local level is work with the people from ISD, work with the joint improvement team leads that you have working with you to really make full use of the data that is going to be available.
And do we have to ask that is done, or is it going to be done sort of across the country, sort of automatically?
I think the offer has already been made, I believe.
Okay,
I think in terms of linking data, I think something has to be signed locally, but I understand that letter has gone out. And as soon as that sort of data sharing agreement has been signed off locally, then the information's, I mean, ISD in Edinburgh is a huge office of great data analytical statistical brains who are and they have computers filled up with all this data that they have, and they are just waiting, as far as I'm aware, to start giving it back to the areas where it came from. It's your data that they just collect and link centrally and ready to give it back to you.
And I suppose the information and data is important, and Brian has emphasised the importance as well, though, of getting information from the communities themselves. And going back to the example about Annandale, so what Annandale might consider as important to them and what matters to them as far as how they're supported and the care and support is provided may not be the same as Nithsdale, for instance, or Stewarton. So it's about, or Stewartry, it's about how you use that information as a basis of conversation, and then identify with communities, for communities, by the communities, about what the kind of key important aspects are for them. And you're absolutely right, the kind of prioritisation process, it's a very easy process to undertake, but the outcome of that process is not always welcome, and it's about how that is worked through with local communities as well, and how they become part of that conversation and part of the whole process as well. So, and it may very well look like in Dumfries and Galloway that each of your localities have slightly similar, but similar but slightly different service provision, because that's what matters to them and that's what suits them, and that's what they've determined with the people, with the commissioners, and local managers, etc. What makes the most difference to and for them. But then we've got to do that within the confines of the resources that we have, both within financial resource and workforce resource as well. So we need to be able to do that in a methodical way, but it has to be, as Brian's suggesting, in a more co-produced way as well.
Katie, going through the sort of point that Brian made, is bottom up.
Yes.
How do you make sure you get the right people at the bottom? Because there might be somebody out there with a really good idea who's a shrinking violet who doesn't come out and tell you. How do you make sure you have the right people involved in the partnership?
Well, I mean, our policy colleagues have developed a communications toolkit, and again, giving advice and suggestions about how to get people involved. Going to where they are, they might be in their lunch clubs, they might be going to various activities, but also about how you engage with the wider public as well and get ideas from them. And nobody's suggesting it's easy. The challenge that we've got, and I suppose this is the other thing, is I was working with one of the other partnerships a few weeks ago, and they were looking through statistics that were very similar to the ones that Brian have mentioned for Dumfries and Galloway. The other thing that they did, and this is possible also for all the partnerships, is they overlaid the deprivation kind of category areas as well, where people are living in more deprived areas. And it was also very interesting to note that the higher users of their health and social care services were not, in fact, the more deprived areas, they were in fact the more affluent areas. So there is that challenge about people who are more articulate, people who are able to kind of state their case, shout the loudest, against, as you were saying, the wee quiet person who's probably got one of the better ideas. And again, it goes back to that kind of resilience and self-sufficiency that was being talked about earlier on. Are people in more deprived areas, do they have less expectations? Are they just getting on with it? Whereas people in more affluent areas are perhaps able to articulate more what they want, what they need, and make those demands on the service. So it's not an easy nut to crack, but it is about being involved with your local communities and using the kind of foundations that you already have, across communities to actually get people to come forward. And I'm not talking about often like huge town hall meetings, which again sometimes doesn't work for some people. They feel intimidated, they won't want to speak in that environment. It's about kind of capturing and giving them an opportunity to even write. So one of the partnerships, Borders, for instance, is embarking on a conversation with you process about engaging their communities, and their draft of, again, they've identified from what people have said already what the overall aims and ambition is, and peppered that with a few statistics, and given people the opportunity to come to meetings or be in touch or send something back to give their own ideas and views, and contact details if they want to be involved in the future. So there are various ways of doing that, but as part of the development of your strategic commissioning plan, you should also have a communication and involvement plan as well that identifies how you're going to optimise as many people as possible within your local communities getting involved.
I think Katie's raised a very interesting point there, and again, it's some of the interesting stuff that comes out of that data about your different localities. So the affluent areas are more likely. I mean, this is, I don't know which area you were speaking about, but I know in Perth and Kinross where they've done it, where they have very good analysis of their data. People with money are more likely to actually use the hospital services. They will get their hip replacements far quicker than people in deprived areas. Now, we can work on the assumption that that's because people with money might be more educated, they might be more willing to stand up for their rights and demand that they get seen quicker, whereas somebody in the deprived area is just going to sit back and say, well, I need to wait, and if I have to wait 12 weeks, I need to wait 12 weeks. We don't know the answers locally as to why, but it's quite interesting, some of the things that data sets up. One of the other fascinating things from Perth and Kinross, and I don't think they're alone, it's certainly the case in neighbouring Dundee, will probably be the case in here, and again, it's something the data will tell you. The nearer you live to the big hospital, the far more likely you are to go to that hospital. Far more likely to be referred by your GP to go to that hospital. The further you get away, and Perth and Kinross sort of sketch this in circles going away from Perth Royal Infirmary, the further you are away, the GPs look after you in the community. The nearer you are to Perth Royal, they just send you into the hospital. So we know what the data tells us, but really that's what locally your commissioning group needs to get their teeth in to say, right, we know this is happening, and we need to understand why, and we need to go out and speak to these localities to find out if somebody in the far reaches of rural Perthshire can be cared for in their own community without ever coming near Perth Royal. What is it we can learn from that area that we can then bring into Perth itself and start caring for people in a different way here? And what can we learn from the affluent areas that they get seen quicker and more often that we can use in our more deprived areas?
Right. Alistair Witts.
Thanks. As you may have gathered, we divvied up questions, but of course it's a much more fluid discussion than being structured like this. But just a point before I put my question. It takes me back to the time when I was a young student and working in a big firm, and the suggestion box was viewed with some disdain in that, one, it's not taken seriously, and two, if it was taken seriously, somebody else would take credit for the good idea. So I think maybe we've still got work to do on that in order to, as I said, the shrinking violet or the serious-minded person. That's just an observation. My question was about, I think in a sense it's been superseded by the discussion, national programmes or support for capacity building. We heard about we don't want it imposed a la Stalinism. I'm sure that's not what anybody wants, but when you a national programme, I hear what you've said about this should come from the bottom up. These are the people on the ground who have the expert knowledge of their locality. So when it says about support for capacity building, I don't know if I should take a pop at the health service. Maybe it's a culture there that finds it difficult to work together with councils and such like.
There's a lot of areas where that's not the case, a lot of areas where that is the case.
Mm-hmm.
And those are the barriers we absolutely need to break down, and hopefully will break down with the integrated joint boards, which have to be made up of representatives of both health and social and local authorities, obviously, and more importantly, have the joint budget, so there's no cost shunting should go on. And delayed discharge is another a real point here, not just because it's another of the things that I am charged with tackling, but just to look at it on a national basis. We have the equivalent of 60 wards across Scotland that are filled with people that shouldn't be there, and people that we are harming by having them in there, and it costs £2,000 a week at least to keep them there, and these people should be in the community where the average cost would be around £600 a week. Now, in terms of commissioning, if we had a national strategic commissioning plan, we wouldn't plan to have 50 or 60 wards that are going to be filled with people that we're harming by having them in there. We'd have them in the community, we'd shut those 60 wards, to be fair, or at least we'd use them differently. We also, how can it be reasonable to say we can't afford £600 a week to keep Missy Smith in the community? But okay, it doesn't matter because we can afford £2,000 of public money to keep them over here, which is a worse setting and the most inappropriate setting for them. It's absolutely bonkers, and hopefully integration will start to break down those barriers. And I think we need to then start, once those barriers have been broken down, I think there's things that each side can learn from the culture of the other, to be honest. There's an absolute load of good stuff that goes on in local government. But there's also a lot of good things that do go on in the National Health Service and in our local health boards that both those cultures, I think, can learn from each other and share the good points and try and bin the bad points.
Thank you.
Andrew?
I have a wee bit of concern that the commissioning that's taking place down here at present is flawed, because we have, or the NHS has at present made a decision with a new hospital and the capacity of that new hospital. Our commissioning process isn't complete. So therefore, how can we go ahead with a hospital that we don't know the size that it actually should be?
Well, that's a tricky one, isn't it? Because in the future, that's going to be the role of the commissioning body. It's going to be the role of the chief officer, really, to dictate the level of capacity that is going to be needed. The vast majority of health service budgets that are tied up in beds will fall to the IJBs. Geriatric medicine, psychiatry of old age, the vast majority of services and specialties that account for most of these bed days will be the responsibility of the IJB. In fact, I think I have it somewhere. No, sorry, it's not one of the ones I wrote down. I did have in the information that they gave me yesterday, the percentage of those bed days that would actually fall to the responsibility of the new integrated joint boards, and it's huge. It's somewhere around 90% of the bed days, I think. So in the future, that is going to be the responsibility of the IJBs and the chief officer and the strategic planning group and the strategic plan to dictate what the level of capacity is needed, both in our hospitals and in the community. It's got to be done, joined up. Things have just got to, you know, it hasn't come in quite in time for that to happen. You'd like to think that on a partnership basis, it absolutely should have happened in Dumfries and Galloway. I don't want to speak about local systems or your local hospital. I have no idea if it's got the right level of capacity that it will need going into the future. I just don't know, I'm afraid. But it really should have been done in a joined up way between health and local government.
But would it not be right then for us to postpone putting this new hospital up at this stage until such time as we do know what the commissioning process is going to turn out? You know, otherwise, we're going to end up with a situation. We have a new hospital, and our commissioning is developed all around the new hospital, rather than our commissioning is being developed around what our community requires.
I'd be reluctant to comment. I don't know which stage your hospital is at, I'm afraid, to be able to comment. I mean, Katie's been showing off her local knowledge of Dumfries and Galloway by name-dropping all these places. I'm sorry that my knowledge is probably based on the street signs as I come down the M74, but I don't know enough about your hospital here and the stage it's at to be able to comment on that. In an ideal world, it would have been planned in a joined-up way.
Yes.
Sod's been cut, isn't it? Sod's been cut in ours.
Yeah.
Yeah.
The other day. So it was based on using, because I sat in the board at the time, using the capacity we had in the healthcare, home care sector to make sure that the people got out of the hospital ASAP, because when you're in a hospital, that's where you get the more chance of picking up infections. But I don't know if the figures were right at the time. Colin?
Sir, it's actually going back to the discussion we had earlier on. It was probably at a tangent, but it's just a very quick one. You were saying about putting NHS nurses into care homes to stop people getting blue lighted to hospital, etc. Well, we have a cottage hospital in Kirkcudbright that has trained nurses who are trained to put intravenous drips in, but because they don't do it frequently enough, the risk assessment shows that they shouldn't actually do it. So we've got people coming from a hospital to Dumfries just because they're not allowed to get an intravenous in Kirkcudbright. Now, the same thing I would imagine would happen with nurses in care homes, that if they weren't doing it frequently enough, they wouldn't be allowed to do it in case they did it wrongly because they're not doing it enough, and then they were sued. Now, linking into what Andrew was saying, we had a discussion with the Chief Executive of the Health Board here that this new hospital is all single beds, and it's all going to be supposedly in there, have your operation, then you're shipped out to your local hospital. Well, 2 years ago I spent a month in Dumfries, 3 weeks of which were because I couldn't go to my local hospital because there's nobody there to put an intravenous drip in. So we seem to have this ludicrous situation which is even going to be escalated further because it hasn't been thought through properly.
I'll let Katie elaborate on it with her nursing background, but I absolutely take your point, and to an extent Jeff is right as well, because hospitals should be somewhere that you go in, you get treated, you go out.
Yeah, but they haven't got the follow-up.
But we need to have the care where it needs to be in the community, and there is far too many of our resources, both money and people, are tied up in our acute hospitals in Scotland, and we won't get the community aspects of this cracked until we get those resources, both money and people, out of the acute hospitals. Geriatricians need to be working with care homes. We have more people in care homes than we have in hospitals. Why then are the geriatricians only based in hospitals and not out in the community where they can be working with the care homes to make sure that people are getting kept in the care homes, or even better, in their own home? Same goes for nursing staff. All the specialists that are centralised in our hospitals, we need to get them out as far as we can and get them working in the communities, training up the people in the communities, that we care for people in the communities, that they don't have to come into hospital, or if they do, we treat them and we get them back again.
What you say makes 100% sense to me, but it doesn't seem to be anybody trying to implement that.
I suppose if consideration has been given to a change in that pathway, as you were suggesting, that then the demand will increase within your community hospitals. So therefore, the nurses there should get the practice that they require. There's a practical that there may be practical solutions in the meantime, though, for those nurses to maintain their skills. So, for instance, when I worked in hospitals in Edinburgh, we used to do almost an exchange scheme, where if somebody was kind of coming to the end of that kind of 2 or 3 year period where they had to upskill again, they would come and work within a hospital environment for a couple of weeks in order to get upskilled, and we would lend the facility community hospital one of our more acute layout trained nurses, and they would learn quite a bit about what was going on in that environment. So there may be some practical solutions that can be worked through on a local basis, but it sounds to me as if the consideration has been given to optimise the use of your community hospitals, which is quite right in people's journey of care. That being the case, it goes back to what I was saying earlier on about the commitment to the development of the workforce. So they need to have the appropriate skills in order to be able to care for people at the right time within their journey, and the earliest time of coming out of an acute hospital environment. So that will need to kind of be worked into the staff development and the commitment to their skills development, as well as that journey changes for individuals. And that's obviously something that you can inquire about.
Well, we have inquired about it, and it just seems that, like they say, the sod has been cut for this new hospital,
Yes.
but all the rest of the plan seems to be a sort of wing and a prayer from now on. There isn't a definite plan in place, and this has came from the Chief Executive. At the moment, it's all, we will need to get these all upskilled people, etc. But it's not we will, or we will have a timeline for doing that.
I said that's it. The legislation and the need for a strategic commissioning plan has come too late in a way for what's happening in Dumfries and Galloway. In the future, that strategic plan needs to take account of the whole spectrum, the whole system of care, your hospital capacity, your care in the community capacity. It's got to be done as a whole system. That's really, the fact it's not being done in many areas of Scotland is the reason that the Scottish Government and ministers and Parliament have legislated to make it happen. So in the future, it will be done hopefully in a properly joined up way. So we hope and keep our fingers crossed with you.
I've got a preset question, which is really about how would you advise the council in regards to the next steps. But I've got a more burning question, is based on about Ivor, if you give me indulge me, in regards to how do you design the commission to produce what we're talking about in regards to delivering services for what we need at a local level. Can we talk about bottom up? And how do we design that commission so it absolutely, there's no way that somebody doesn't see this as somebody within a certain department doesn't see this as an opportunity to start empire building. Oh, I can just get another 3 or 4 managers, layers of managers, and start building, and I'll get up the scale, and that's how it works. How do we actually see this commission needs to be designed in such a way that it delivers the services that are needed and required from the local folk? So how do we do that?
I mean, we've legislated for localities, we've legislated for the strategic planning group that needs to have representatives from those locality groups. It needs to have third sector, independent sector, user, carer involvement. Housing is another one that we haven't mentioned so far that needs to be on that group. So we have legislated to make that happen, and it will be the responsibility locally of the chief officer reporting to the integrated joint board, which, like I said, will be made up of elected members and board members from NHS Dumfries and Galloway. That's the sort of reporting structure and the responsibility. So the chief officer needs to make it happen. But we have legislated really to dictate how it should happen from locality up with the strategic planning group with full involvement.
So I suppose, I mean, that is a clear process. I can understand it. It's just, because it's, I mean, we spoke about what is commission and what is procurement, as long as as what you referred to as you started your presentation. We did the same. What is commission, what is procurement, because they're so close together. Yeah. But we decided that commission is running a bit more of a strategic brief.
Absolutely. I mean, the guidance itself, and just about all the briefing, it's probably somewhere in your own older people plan, has this cycle that was devised by the Institute of Public Care. It was adapted by SWIA. It looks like that, if you can see it. And really, it's the analysis, plan, deliver, review bit of the cycle. And all the outer bits here are the commissioning parts, dictating the strategic needs, etc. And the inner circle is the sort of procurement bit of it, delivering, contracting to deliver, and purchasing to deliver what the strategic commissioning elements have dictated.
So going back to my original question, what are the best next steps for the council, for Dumfries and Galloway Council?
I presume, have you got localities at the moment? Has it that they've been
for all district councils? Yeah.
And a chief officer, I think, has been appointed. Is that right, Julie?
You've got a strategic planning group.
Has it been established? I know you had the meeting in February.
You had good workshop in February.
Looking at it next week, I think, draft.
I mean, that strategic planning group and dedicated planning officers from the council and the board need to now sort of bring that, and the data that's going to be available through ISD, need to bring that to a fruition, to a first draft of a strategic plan, at which point it needs to go wider than that strategic planning group and be consulted on, at which hopefully you will get a range of views and interested groups will come in and have their say, and hopefully it will be the people with the good ideas and not just the people who shout the loudest. So it sounds like you have the structure in place. I'm not, I'm afraid, totally up to speed with where you, I mean, Christina would probably have been a bit more knowledgeable of the local circumstances.
I think the important thing as well, as we mentioned earlier, was that communication plan that the strategic planning group need to develop, with and for the localities. So it's about how they're going to get the information from individuals, those conversations that will help influence what occurs within each of your localities. So that's probably a really key important step, because you want to be able to know how to access those communities, get their feedback, get that influenced within your strategic plan and take that back to them and see how that kind of fits. So there has to be that process in place, as well as the kind of number crunching and all the other bits that need to go on in the background as well. People need to be able to see, what their community is made up of, what resources are being spent in their communities, and that information should be available to you. Through the strategic planning group, through the support from the analysts, etc., and the conversations. And I don't think anybody's starting from scratch here, because I think we've got to remember that. So you've got care groups as it stands. So people are having conversations with those care groups as they stand, whether it be carers, older people, those with mental health problems, disabilities or whatever. So there's probably a reasonable infrastructure in place already, to gain views and I get ideas from people at a local level. But the communication plan is you've got to be absolutely deliberate that you're going to do that, not just kind of think, oh, we'll speak to whoever turns up. You've got to be deliberate in, contacting folk and giving the opportunity to look at the information and give them their views back.
It sounds like there's two sides to that. You've got the service user, but you've also touched on it earlier, you in particular, the staff.
Absolutely.
They'll come up with some fantastic ideas, save £250,000 within a couple of years, but there's a management structure, there's a blockage there somewhere that doesn't allow that to come to the top, and that's the communication. I don't know if that should be picked up there. How does that? Because I think we see it in the council, we see it in NHS as well, see it there as well.
Andrew?
When the plan is completed, take it the process as it goes up to your own department for scrutiny. Where does it actually go to there?
It gets signed off by the joint board. It's a local plan. Doesn't come near us. We'll have a don't get me wrong. We'll have a look at it, and the joint improvement team will look at them all, and for no other reason than to share the good practice. But locally, it is signed off locally. It's a local plan.
But it doesn't get an independent overview by anybody.
You have to issue it for consultation.
Yeah.
It goes for a public consultation, but ultimately it gets signed off by the integrated joint board.
One of the things we haven't mentioned is the scrutiny element associated with the plan, and the legislation also identifies that the Care Inspectorate, jointly with Healthcare Improvement Scotland, will be scrutinising your plan against the key principles of integration. So they have to feature quite highly within your plan, and about how you will develop plans and what activities and actions will take place in order to adhere and fulfil the principles of integration as set out in the Act. Christina and I have had sessions, and obviously Christina's you've got quite good contacts within the Care Inspectorate in particular. We've had discussions with both the Care Inspectorate and indeed Healthcare Improvement Scotland, again to give them an overview of the commissioning cycle, the timelines that people are being expected to work to, and obviously what we have suggested to them is they need to kind of be behind the curve a little bit. So if you're developing and producing your plan by April 2016, we don't see much value in them coming to then see you in July 2016 to see how you're implementing your plan against the principles, because you're just kind of starting that journey, if you like. But there will be scrutiny associated with your commissioning plan.
No, I'm very pleased you mentioned that, because I was really concerned.
Yeah, absolutely.
If you have just 2 or 3 major bodies that take forward a plan and it's not really getting external scrutiny.
And I mean, obviously the Healthcare Improvement Scotland and the Care Inspectorate have been again developing a framework about how they will do that, and they've also been involved over the last few years about with joint inspections for older people services, for instance, which again looks across the whole system of both community and hospital elements of care. So that's something that they are becoming more experienced at as well. But they're in the process of developing a framework of scrutiny associated with the principles in the Act.
And ultimately the proof will be in the pudding. We can look at a plan and it'll be a very well written plan with wonderful data and presented in lovely colour charts, but if it doesn't deliver, it's not a good plan.
Mm-hmm. The doing and reviewing elements are as crucial, if not more so, than the analysis and the planning part. So what it is you actually do differently, how people respond to that, how you can measure that there are improvements to their outcomes and to their experience overall within your communities is really, really important. So again, work with performance frameworks that not only count the hard numbers, and obviously Brian has identified a few of those today, but also get the outcomes and the experience of individuals as well is really important and a really crucial part of the plan itself. So how are you going to measure performance? How are you going to identify that you have improved outcomes for not only individuals but wider communities as well? So that's a really important part of the plan.
I think if there's one thing I would say to you about developing your plan is that in the past, planning has been done on the basis of what do we do at the moment, and how do we do just a little bit more or a little bit less of it, and don't do that. Take this as a new approach. Take this as something new, and just take from your locality level and at a very also broad level, what is it we want to do and how are we going to do it? Not what we do at the moment and how do we just tinker with that.
It's interesting you say that, Richard. I think that's what happened with Curriculum for Excellence when it came into education. There were some schools were really great and they took it forward because they didn't think about what they'd done in the past. They looked at how their vision was going to be for the future. And those that were stuck in the past stage.
Right, well, kicked this about for quite a while. One thing, if you can have a brief answer to this one, that sort of we found in the council was when we had our commissioning managers from across different services in, there is a slight different understanding of what commissioning is. Have you found that when you've went out through public sector, private sector, third sector and independent providers, you know, is there, well, that's not actually what it should be? Have you found that difficult to?
It's getting a lot better. I think when we started this a few years ago now, I think at the outset I said to a lot of people, particularly in the NHS, commissioning was just a dirty word. They said we don't do commissioning. Now they think that because it's basically their provision is all in-house. But what we are talking about is basically planning with money and looking at the strategic outcomes you want to achieve, how you're going to do that. So the NHS should be doing commissioning, you know, just because they don't like the word. Now I think things have changed. I think there's now an acceptance of the terminology. I think I said earlier I'd give you an example from the Highlands, and I think this is one of the areas where it has evolved, and there is now a joined up understanding of what commissioning is. Because when I went up to Inverness a couple of years ago, the NHS had their view, local authority had their view, third sector their view, independent sector theirs. Probably the nearest to ours, to be perfectly honest, was the third sector's take on what commissioning is or should be. But now they have taken a collective, collaborative approach across their home care services, and remember that the home care is now delivered by the Health Board because of the lead agency arrangement. They pay a tariff, they have an agreed tariff that's agreed between all the sectors of £18.59. Now the reality was that they paid the private sector far less than that in the past, and in terms of the actual cost, they paid themselves about £30 for each hour of home care that was delivered, was the total cost to council. So they now have a level playing field of £18.59 that is payable, whether it's in-house, whether it's external, and it's paid to all the people that they contract with for their home care service. So it's done away with the infighting between different home care companies. There is a truly collective, collaborative approach is now taken to home care in that in a certain locality, if suddenly one provider has various people off sick, another provider will step in and say, we will cover your hours, because collectively that they have I won't go into contractual arrangements, but there's a lot of clauses in the contract that they can be fined if they don't deliver X and Y. Again, that's a procurement part of it. But they take a collective approach now and help each other out, which is almost unheard of in the delivery of home care, I think, in any other area, where it is dog eat dog, really, and independent providers are fighting each other to get the work. To the extent that apparently a company from Glasgow saw some rich pickings up in Highland and moved up and said, right, we want to deliver home care in this particular locality, but we're not happy with these clauses in the contract that might fine us £200 for a missed visit. We can't possibly have that, because reality is we will miss visits. And they were told, well, you can go back to Glasgow then, because that's how we do it in the Highland. I guess you can't just dictate. We're not dictating. The sector, the home care sector, has agreed all this. We have taken months to agree it, but we have agreed this. This is how we are going to commission our services. Everybody's in line, so if you don't want to sign up to it, off you go. And that, to me, is a truly collective approach to the commissioning agenda that we would want to see.
And just very quickly, I mean, the Joint Improvement Team have also had discussions with colleagues who work in purchasing and procurement environments, for instance, and we've been working with Scotland Excel, again, to try and kind of broaden folks' minds and raise awareness about what the new kind of commissioning planning arrangements are, and the really important relationship, and in fact, the value of having procurement and purchasing colleagues, you know, around the table when they're talking about strategic planning, because after all, they often are the folk that have the market intelligence. They know what's going on. They know where there might be, you know, some crisis coming up. So they actually know what's going on in the market as well. So the relationship between commissioning planning and the procurement colleagues does need to become much, much closer together. And again, I noticed in your event in February, you had colleagues from not only hospital commissioning, but council commissioning and procurement as well, which was really, really useful to see about that kind of coming together, so that everybody is kind of moving forward in the commissioning plan development together.
Really quickly now, but just in regards to that, having that standardised fee or charge, hourly charge, what effect did that have on delivering the living wage.
That's part of the contract. The contract that sits underneath the general agreement insists on those providers paying the living wage to all their staff. The beauty of it is that they've worked out a rate that includes mileage, includes travelling time. So this is a truly hourly rate that is designed to deliver better outcomes for people, that we're not just going to have sort of 15-minute visits and set mileage time that you've got to be there and we're only going to pay you this. So it takes in all of that. I think it's now a matter of public record in Highland, so you're welcome to get in touch. Their head of commissioning is a gentleman called Simon Steer. I'm sure he'd be happy to share details of what it is they've done in Highland, because it's early days. I mean, it's only just been implemented, but it looks a very good scheme. He talked it up very well, I must admit, but we're quite hopeful that it's going to work.
It sounds like something from the event that I attended, the seminar, and here there was concerns about how we actually get to a level where people aren't actually paid below the minimum wage because they're actually travel time doesn't count. So that might be something that we do pick up on. Now, is there any final questions, burning issues that we would like to ask Katie and Brian when they're here just now, when we've got the opportunity? Andrew?
Final one, yeah, what advice would you give our council about the next steps? Have you?
Yeah.
Sorry?
And he gave it
All right.
went through the strategic plan.
Oh, right,
Communication
yeah.
plan.
I'm glad you reminded me of what
Give a different answer.
I'm actually going off to the health board now, so I'm quite happy to relay your concerns to the health board when I being in the area, I'd asked if I could go down and meet with them as well. So, as long as you're all right with that, I'm happy to sort of outline the gist of the discussions. So.
Yeah,
That'll be fine.
Yeah.
yeah, be good.
Very interesting.
Could I thank you both for that presentation? Come down and
Thank you for the invite.
I'll just end this session with, we go back to the recommendations. We've received the presentation from Brian and Katie, and agree this should be added to evidence gathered for the commissioning review. Happy with that? Thank you. You can stay if you want, or you're welcome to leave.
It's informality actually brought together there.
Exactly, and there's so much taken ahead to read that.
I said I've got a preset question, but I asked another question. Then I went back and I said, that's what the preset question is. So it was confusing the way I worded it.
John Patterson, who's he?
He's
Chair, if you excuse me, I'll put my apologies in. Okay, sorry about that.
no problem. Right. I think Ian used to be about quarter past.
That's right.
Alistair, half past. So
Yeah.
try and
Through.
the agenda is
Chair, I thought that was very good. They were very interesting, those two.
I've got to leave at 1 either before I've got a meeting at 2 o'clock in Kirkcudbright.
No problem. Right. If we move on to item 5, scrutiny review, phase 2 commissioning, feedback on roundtable discussions with the council commissioners. This is the feedback from the very illuminating discussions we had with council commissioners last month. From the review, is there anything that we feel that was missed out or amendments that we would like to make to it? Any comments or queries from members who were not present?
Is this the time to bring up the fact that we sort of do need a procurement team?
That came through the procurement review, didn't it? Then there's
So we don't need to reiterate it in any of this? No.
It's in the previous recommendations in the procurement review.
Okay, right.
This is what I was referring to when we got into the discussion about what commissioning is and what it isn't. Because we spent quite a bit of time on that, didn't we?
Yeah.
Because it's close links to procurement. It seems very much the same, but it isn't. It is the brief. It's the overlying brief.
that get everybody together. This is what we need to deliver and bring back your ideas, and this is how we can do it. It seems to be the commissioning role rather than basic
I
procurement.
thought that Brian's short explanation was extremely
I wondered if it should be
nailed it.
somewhere on anything that's to do with commissioning.
Yeah.
Do you know what it is you're trying to do?
We'll certainly capture that and record it.
Because it is a
It's
defined.
quite a good reminder
Yes.
for people, you know, and to focus on what it's about rather than think they know, if you know what I mean. I agree with you, Colin.
Alistair?
Several comments, if I may, Chair. Presentation, the roundtable discussion. Bullet point 4, sir, it's already been mentioned earlier. Term commission appears to mean different things to different departments, and there's no common understanding. That has got to be addressed. That's got to be cured. If we're really going to be serious about taking this forward in a meaningful fashion, as we're obliged to do, that's the first point I make. Second one, bullet point 7, Chair. Commissioning is very established within social work services who plan the whole process at a strategic level to ensure the delivery of the required outcomes. It'd be good to see, and I wasn't at the meeting, but it would be good to see some evidence, confirming that if it's not an exemplar, at least it's effective. That would be helpful. It's well established, which is one thing, but as I say, well established and effective would be particularly helpful as far as I'm concerned. So I'm going over the page, Chair. Discussion with elected members. Bullet point 9. Again, it harks back to the discussion in the presentation. There is a risk of some departments working in silos rather than sharing their knowledge and expertise. The commissioning process within our council should be integrated and simplified and fit for purpose for each service. I think, I agree entirely with the profundity, for want of a better term, of that. But again, Chair, we're going to have to ensure, in fact, that these problems, these issues, are addressed and overcome. And again, it would be helpful, to have some sort of monitoring process in place, to ensure that is indeed the case, because very often, there can be slippage in that. I'm not missing stories of anyone. And the last one, Chair, you'll be pleased to hear, bullet point 10. The outcomes of some commissions are difficult to measure as they are a long-term goal, e.g. school meals affecting the health and well-being of pupils. I can hear Dr. Cox's voice on that one. And I hope that's taken in the spirit in which I'm proffering it.
I think the 2 points you bring, can we make sure those are added in? I think, especially the last one, how we make sure that we do get things across the council. That'll be part of the recommendations, I would think, that we'll take forward.
Yeah.
So that was...
That silo thing, that leads to empire building. That's where I was kind of coming through as well. It does. Because that silo mentality, you'll end up with an empire that you can't move, and you have no control over.
That's perfectly true, Chair, but at the end of the day, I mean, your whole, this is the way of the future, no two doubts about it. And if we don't resolve that difficulty, all our efforts ultimately, as far as I'm concerned, will come to naught.
If there's nothing else, we have the recommendations there. We've considered the summary, and we've added a couple of bits and amended the bits. Gillian's picked that up, so that can we agree this should be added to the evidence gathered for the commissioning scrutiny review? Right, thank you for that. Item 6, scrutiny review, actions and next steps report. This is a visual summary of what we have done and what we're going to do. So, do members have any comments or amendments?
Take it, Chair, there is a wee typo there in the appendix in the box, the far right box, the background sessions. We're talking about report to July, I think it says 2013, I take that's 2015 for me.
The top one?
Aye.
Or
is that already?
That'd be the initial presentations.
All right,
We did
okay.
that.
Fine,
as
that's
part
fair
of the
enough.
original.
I stand corrected. Apologies for.
We had the two together, and then we decided to split them up.
Aye.
So it was 2013.
Right, it was 2013. My apologies.
No problem. Right, if there's no comments, are we happy to note the progress and actions taken for phase 2? And we've reviewed and agreed the next steps for the scrutiny review as set out in the appendix. Happy with those?
Yes.
Move on to item 7. Scrutiny review, public involvement, feedback and national standards briefing. This is the first piece of evidence we have taken for a review on public involvement. It gives us a starting point for how we undertake our involvement and engagement work. Are there any additions or amendments from members who were present at the workshop when it was presented, and is there any comments or queries from members who are not at the initial workshop? Because my recollection, there might not have been many as there, but it was getting late in the day and people had to leave. It was meant to finish at 4 and I think it was after 5 or something before we got tidied up. Comments?
Yeah, can I just do a comment on page 19, which is the language, terminology and community engagement, because I think the language in that is not great, if I'm being perfectly honest. When it says informing, you know, this means we are only going to tell people. I don't think the word only is very helpful. I think it's very almost dictatorial, and I don't think that is.
The wording was meant that, well, actually, if you're informing someone, you are just going to tell them, but I understand it means that it'll feel, the way it's written, it is sort of, right, you're here and you're only going to be told. It's not that meant to be that way.
Well, it doesn't read well. And then consulting, this means we'll offer people restricted options to choose between. No, consulting means I would have said was you go out and you ask people for ideas and things sometimes. It's not restricted options always.
Well, the view
people
that was
think they have
given
an
was
opportunity.
engaging was the actual, where you're actually asking them,
Yeah,
what do you really want? And then once you've got those answers, you have 2 options or 3 options that might deliver what they'd asked for. Then you go out and consult on those 2 or 3 options.
Well,
that was the difference that was given by Mary when she was here, I think.
I mean, I think that is a fair point actually about what do we mean by these definitions.
And I don't think
I think that's something that will actually come through your review, getting a shared understanding of what we mean in each of these.
Because I don't think it's entirely right here.
There, certainly, I think are worth exploring over the course of the review.
I think communities would think, if they were asked to go for a consultation, they would think that was what engaging was, that this means the community will influence options and choice of actions. Mm-hmm. This means the community will share in any action taken, you know, to support community-led actions. Whereas consulting, this means we'll offer people restricted options to choose between. I don't think that's very good. Mm-hmm. I don't think that's clear. It's not clear in my mind, if I'm being perfectly honest, because that's not what I see consulting about.
Because I think those were taken out of the actual definitions given by the public engagement and stuff.
From the national standards.
Yeah, national standard.
But if people go to something where they're going to be consulted, quite a lot of people do feel that they have the opportunity to influence. Yeah. And if it's very restricted, then you have no opportunity to influence. And I think you might as well just then go to inform, if I'm being perfectly honest.
Yeah.
I found this, Chair, extremely thought-provoking, you know, and I would, you know, I do take the point that Max is making, that, you know, it might be more diplomatic and polite to say that, well, we take out the only, we are going to tell people what we plan to do. But I think the important thing, the point that I really would want to make, sir, is that when, you know, if we've got these definitions or this terminology embedded at the core of the council, it's absolutely imperative that we disseminate that as widely as possible to the people of Dumfries and Galloway and to their other representatives, such as, I mean, how often have we sat at community council meetings and listened to community councils, very often with justification, you know, saying, well, we've not been properly consulted. But maybe the object of the exercise was never to consult them at all in accordance with this terminology. And I think, you know, we've got to get that point hammered home and make it clear that, you know, it becomes, it's almost, you know, second nature. You know, when a community council gets something from the council, the first thing they determine is maybe even a wee box, you know, the first thing they determine is, are we being informed, are we being consulted, or are we being engaged with here?
Yeah.
And it starts off right at the very beginning, avoids obfuscation and misconception, and we will all benefit as a consequence. And I think that's the big issue. I've no problems with, though I would tend to agree that it might be politic with a small p to take out only. But as I say, I think, you know, we've got to get this, as I say, hammered home and make sure that everyone knows exactly, you know, what the definitions are for us all.
I actually think it would be better if they'd been turned on their head as well, because if you think of the process, you would actually start with engaging,
Yes.
then you might move to consulting. After you've done the engagement,
Yes,
you've got
and then
the
we would
view,
inform.
then to move to informing.
Yeah, I would agree with that.
So that's maybe something.
I think that does, Chair, because I mean the way it's set out there, you know, you could argue that connotes a certain degree of negativity.
Yes.
Whereas if you turn it on its head, as you've said, that engaging is obviously the widest of the three.
Yes.
Colin?
Will there be an opportunity to get some facts and figures on how much consultation actually costs the council?
Yes, and that's
there
very
will
much
be.
part of your ongoing review over the coming
I know
months.
2 years ago the budget consultation in the Stuart Way was on the board and news being reported as costing £30,000 for the 3 events, which seems to me an awful lot of money just to have some people gathered in a room. So it'd be nice to know how much money we spend in consulting, and do we really need to consult as much? We seem to consult, and it must cost an absolute fortune.
An officer once told me about a former councillor who said if we stopped consulting we could spend the money on delivering services.
Correct.
I'll not embarrass the officer or the member,
I would fully agree with him.
But Chair, if you're going back, you know, that was one of the big bones of contention. You know, was what the council doing? Were they consulting? Were they engaging? And you know, this is one of the areas, and we particularly there were particularly certain community councils in Mid Galloway were exercised by that process of what they perceived to be the lack of proper process. And again, I think this has got to be clarified for the future. Again, there's got to be a balance between cost and between the standard of engagement, engagement in quotation marks in a generic point of view. And that's already alluded to in one of the earlier reports. I'm afraid, with regards to the deference to Colin, that I would not agree that you save the money in consultation and you'll spend it in delivery of service. I hope that the officer in question, and I wouldn't want to know who he or she was, but I would hope they were saying it firmly with their tongue in their cheek.
They were just relaying comments from the former member of the council.
I'll not make any comment with the member, you know.
With that, we've got the recommendations, considered some of the evidence. We'll put in the points that have been brought up with regard to that and agree this should be added to the evidence gathered for the public involvement scrutiny review.
Yep.
Item 8 is the next steps. It's here for comment, amendment as we feel.
We'll add in just at the end there about the profile information, about getting you some information on the resources that have been allocated to public involvement. Your point there, we'll get you some examples of pieces of work that have been done in terms of engagement.
We note the progress that has happened so far. And is there anything that you wish to review with regard to timetables? Or if not, I'd be happy to agree them. Thank you for that. Item 9 is a scrutiny review on access to services and use of public buildings. This is here for the same reason. If there's anything members wish to add that isn't in there who are present, and if there's any questions with regard or points that other members wish to raise who couldn't attend on that afternoon.
Will there be any public buildings left in them? Parts of them, Dumfries and Galloway, Chair, by the time we've finished the overall review.
Well, we're hoping to do some of the reviews through the summer, so hopefully they're not all closed to then.
going to see new integrated facilities.
Yes. And let me repeat, Chair, what I've said previously. I've been in the integrated facilities, particularly in Stranraer, and that did exercise an awful lot of people. As far as I can see, it's turned out remarkably well. So we're remiss not to say that.
With that, if there's no hands going up, I take it that we have considered the summary of evidence, information provided in the presentation, detailed in appendix, and agree that this should be added to the evidence gathered for the access to services and use of public buildings scrutiny review. Item 10. This is actions and next steps from the previous report. We're asked to note and review and agree. Is there any issues in there that members would like to review or change at this point? There's no hands going up. To note at 2.1 and agree the next steps for the scrutiny review as set out in the appendix at 2.2.
Agree them both.
Move on to item 11. Consider the summary evidence for the town and village improvement scheme as detailed in the appendix, and as with the previous reports of this kind, any comments, additions, amendments that members wish to make?
I think that just the thing that was brought up at the workshop was that I think it was in Dalbeattie, they'd got together several shops and come in with one application in order to improve the centre of the town. I think that's quite a good way forward, rather than just one shop or one building in the middle of a town having itself facelifted. The Chamber of Commerce, or I don't know who it was, had worked together and they've got, and I think that's a really good thing for a small town, that they get their high street looking good, or one area of their town all looking nice. You don't have one in the middle that isn't interested, can't afford it, whatever. Somehow they work together and just improve the whole area. I thought that was quite a good way forward and quite a good idea, actually.
An incentive there would be, if one shop applies, they get 30%. If two shops, they get 40%.
I don't think we were getting anything like an incentive. I think it was just a very straightforward grant.
There weren't many shops in Kirkcudbright took it up.
No,
There's only
absolutely
two.
not. Yeah. But Dalbeattie, I think it was Dalbeattie, was it, that were taking it forward as a sort of almost like a block.
It's an economies of scale almost.
Economies of scale, and I thought
things
that was
they couldn't normally do,
and I thought that was a good idea.
They were able to do.
So I think that might be should maybe be promoted. I don't know how we can do that.
I would hope, Chair, that this scheme, and let me say I'm an unequivocal supporter, but I would hope that this will be perceived as part of the wider process, because the issue, which is certainly exercising my two Mid-Galloway colleagues and myself at the moment in the Mid-Galloway context, is the incidence of dereliction in all too many of our communities. And I would, I know the independent group raised it recently with the Chief Executive. It was certainly raised with the Chief Executive in the SNP group on the 1st of June. And my concern is that if dog fouling exercises the communities in Dumfries and Galloway, I would like to think that the existence of dereliction and the blight and the adverse impacts it has exercised the 47 elected members in a particular fashion, because we've discussed this on various occasions, we've allocated resources, as it were, to tackle it, and I would have to be honest and say that, without being censorious of anyone, certainly in my part of the world, the results are not commensurate with our desire, as it were, to get the problem addressed. And while I would not wish to be critical of any particular service that the council run, Section 7 of Section 179 notices You know, when you do get them, it seems to be on the basis of elected members' decree that they will be served, and it's, you know, the response that you seem to get by and large, and I say it with a certain amount of diffidence from professional planners, is that they will tell you, you know, the reasons as to why they feel it's not appropriate to do so. Now, we've served them in properties in Newton Stewart, we've served them in properties in Wigtown, we've served them in properties in Whitehorn, and at the end of the day, only one was challenged, interestingly enough, and it was only that, you know, we were told by the Scottish Government that no, our timescale was just a wee bit too precipitate. So they gave the property owner in question an extension. But the concept, you know, of these being served seemed to find favour, as I say, in the occasion when it was challenged. And I would like to think that, you know, this, important as it is, you know, cannot and mustn't be taken in isolation. I go back to, for instance, the bid scheme in Stranraer. My understanding is that, you know, they also have the right, you know, to operate, you know, shop front improvement schemes, and, you know, yet. For anyone that knows Stranraer, you've got the massive elephant in the room sitting there in the centre of the town called the former George Hotel. And unless you can, as I've said, no, for the first time, it's all very well talking about, you know, renovating the sea, you know, refurbishing the seafront, regenerating the seafront is the word I'm looking for. But if you leave something like that mouldering and decaying, and blighting, you know, the very core of the town, and I'm sure every other community, you know, or every other member sitting here, you know, will be aware of the issues in their area. If you don't tackle it as part of a holistic approach, we will not get anything like the benefit from it. So, forgive me, Chair, long-windedly, what I'm really saying is that cri de coeur, for want of a better term, I would like to think that, you know, we don't lose sight of the other wider and more damaging issues of blight and dereliction.
I think one of the things you find with this is the fact that when you do one or two, it encourages other people to do it. And like you say, if you've got 7 or 8 properties and the one slap bang in the middle is derelict, then there is a feeling out there that something should be done about it, and it's maybe how we, through this scheme, actually go that next step. Now we've got Alistair and then Ian.
On that particular point, it was just because I was waiting for 12 if I can, because I'm running over my time. No, just I think, is that the place to pick it up? Because we've got certain allocations. We've got to look at the Beast and Lock of 80. I think Annan should be put in there as well as a particular project to visit and understand. Being the River Gateway project, I want to be with on this, you're saying would be the same. Just about advice in regards to that.
About enhancing the scope of the review.
Because I've missed this last year where this was agreed. Because I think it's, I've mentioned it many times in the past, but obviously I missed where that decision was made.
It was during the review, they showed
that we're looking at.
the fishermen, was it fishermen?
No.
The anglers. And they showed the Tate & Co. across the road that they got some money from.
Jason says that was just a facelift alone.
Yeah.
But this is, that was, I mean, that's all I remember is talking about the facelift scheme.
Yeah.
But this is talking about wider regeneration stuff within. Again, it's not just about facelift scheme. We got a presentation on the facelift scheme from memory. I'm talking about wider regeneration projects. I've mentioned that many times in the past.
Certainly this report here, this is the first piece of evidence that you're getting for this particular scrutiny review. So this is about the shopfront improvement scheme. As your review goes on, you'll get other pieces of evidence, and I think the derelict buildings scheme, absolutely, we can get you a session in that.
I think, Chair, we've got to
I think what you're talking about, is about adding Annan into the review objectives to as a particular thing to look at.
That's right.
I'm sure.
On this point,
right,
if I may, you know, in relation to Annan, I mean, the dereliction in the harbour area of Annan, you know, has been well recognised, for instance, with the likes of the Fisheries Local Action Group, where you've been getting funding, etc., for that. And the wider issue, I think we've got to adopt for the future as a council a much more rigorous and robust approach to tackling the problems of dereliction and blight.
Alistair.
Just a comment on, I hope your comments in there well-founded. You say that people get exercised over dog fouling, but I think he's meant, you know, implying that they don't seem to be quite so exercised over dereliction. I hope there's not a fatalism creeping in there, in that they feel that something can be done for something is done the dog fouling, but oh well, they're not doing anything about the buildings falling down.
I think it's more from public don't realise what powers we have to do something about it. What I was going by, if you take, I don't know if you need to declare an interest now, the shop I have, we've done a bit of work in ours. One next door's done something, one across the street's doing something, and another one's done something. And there seems to be, if someone does something on the street, a sort of, it builds momentum. That, you know, oh, we could all do something. And I think it's quite a good starting point. But there are some areas where, you know, if you don't have it, the derelict building doesn't just stand out as much because it sort of blends in a wee bit. But if you've got something that's really nice, something that's needing something, I think it draws your eye to it more, and you need to do something. And hopefully that will encourage the council through this process to actually serve 179 notices rather than, oh well, we'll just let it go on because nobody said anything.
It was embarrassing last week to be in the company of our guests from our twin town of Giffhorn who said very nice things, but one gentleman, one councillor said, it's a very nice town, but you do seem to have a lot of derelict buildings.
Yeah.
And I couldn't really answer him, apart from perhaps ask if he had a sort of fund of something.
It's just up the road here, there's a, I think it was an old jewellery shop, and there's a shutter in there, and I think since I went to school, which is 30 odd years ago, there's been pigeons going in and out of that shop above the shutter, and nothing's been done. I wouldn't like to go in and see what it's like now, but things like that, that shop should have been something done and done up with it.
Chair, as a lifelong pigeon fancier, I hope you're not been disparaging to man's oldest feathered friend.
No,
I'll leave it at that.
Definitely not.
On the pigeons.
Right, with that, and the comments made, we've considered the evidence and information, and we're happy to agree.
Aye.
This should be added, and we'll look at the scope with regard to the other parts. Item 12, note the progress and actions taken and review and agree the next steps. And
so we'll update the scope by adding Annan in as one of the key town centres, and we'll, in your forward work programme, we'll bring forward a session about derelict buildings, how we're dealing with them, and
Thanks,
the effectiveness.
I think also Councillor Gilroy's point in the discussion around the
Sorry,
but the
yes,
incentivisation,
how that was good.
that might work
Yeah.
in terms of cumulative effect.
Yes, yes.
Perhaps you should send a copy to Giffhorn.
Didn't think much is
After, when your review
German accent.
recommendations come forward, we'll send that to Gifford.
With that, are we happy to note the progress and agree the next steps as amended? Yes, thank you for that.
Well done.
I have no further business, and I thank you for your attendance today. I think there's been a lot of background work done on these reviews. Our next meeting is on 20th of August, and our next workshop is the 21st of September. My understanding is we have visits arranged prior to that, and hopefully we can all, or as many of us can, attend those and see various areas and various projects and schemes across our region and other regions as well. Thank you all for your attendance.